The complete or partial blockade in movement of gastrointestinal contents distally, it's called as intestinal obstruction. There are broadly two types of intestinal obstruction, dynamic one and adynamic one. Before that, let's see some statistics. 80% of intestinal obstruction that we see is it involves small intestine. 80% of the times we see small intestinal obstruction, and remaining 20% of the time we see large bowel obstruction. In this small intestinal obstruction, 80% of the times it is due to benign conditions like hernia or due to adhesions. There will be intestinal obstruction, small bowel obstruction. In 70 to 80% of the times, the large bowel obstruction will be due to malignancy. Now let's see the types of intestinal obstruction, that is dynamic and adynamic one. The dynamic obstruction is there is obstruction to the movement of the intestinal contents by intraluminal blockade or due to the formation of strictures in the wall or due to the adhesions which is causing the obstruction. So we have three types of dynamic obstruction, that is the causes outside the wall, the causes inside the wall, in the wall, that is formation of stricture, and the causes in the lumen. Adynamic obstruction is there is no mechanical obstruction for the flow of intestinal contents. In dynamic obstruction we see mechanical obstruction, but in adynamic obstruction we don't see any mechanical obstruction. There will be loss of peristalsis, that's muscular movement causing paralytic ileus. This is adynamic obstruction. It may be seen post surgically or due to spinal injuries or due to uremia and other conditions. Coming to dynamic obstruction, which is a mechanical obstruction, the causes outside the wall are the more common ones, which causes mechanical obstruction. In adhesions are the most common cause of intestinal obstruction. Seen in 40% of the patients, adhesions is the cause for intestinal obstruction. The adhesions is usually formed post-surgically, meaning after some gynecological procedures like cystectomy or hysterectomy, C-section, or any surgical procedures like appendicectomy and cholecystectomy. There will be formation of adhesions. These adhesions will cause volvulus, which is twisting of intestine around its own axis, or intussusception, which is telescoping of intestine. Due to these causes, there will be acute intestinal obstruction. Adhesions, I already told that it's the most common cause for intestinal obstruction. Followed by hernia. Hernia, there can be strangulation at the level of neck of the hernia, causing intestinal obstruction. Coming to causes in the wall, involving intestinal wall, there may be stricture in the intestinal wall. The stricture may be secondary to malignancy in 20% of cases. It may be due to tuberculosis, which causes stricture in the intestinal wall, or due to Crohn's disease, the patient may develop stricture and intestinal obstruction. The causes in the lumen, meaning there is mechanical obstruction inside the lumen. Something is coming and blocking the flow of intestinal contents. This can be gallstones, which is secondary to formation of choledochoduodenal fistula, or due to the roundworms inside the intestine obstructing the flow, or due to inspissated dry hard feces. This is the causes for dynamic obstruction and adynamic obstruction. So coming to pathophysiology of this condition, intestinal obstruction, we see the changes proximal to obstruction, the changes at the site of obstruction, and the changes distal to the obstruction. The changes proximal to the level of intestinal obstruction is, that is proximal. We have in first 24 hours, it's divided into two parts, in first 24 hours and after first 12 hours and after 12 hours. Initially, there will be increased peristalsis. There will be vigorous peristaltic movement immediately after the obstruction. There will be vigorous peristaltic movements proximally. It tries to push the obstruction and try to overcome the obstruction. So due to this vigorous peristalsis, through the obstruction, air will be passed. The air will pass through, and it has a churning kind of effect, which causes multiple air fluid levels seen on X-ray, which we'll discuss in investigation. And after this increased peristalsis, which is trying to relieve the obstruction, the obstruction may not be relieved, or it may be relieved. If the obstruction is not relieved, then there will be the paralytic movements will cease to exist. There will be fatigue in peristaltic movements. So there will be ceasing of peristaltic movements. So the gut will be paralyzed. And after the disappearance of the muscular movements proximal to the obstruction, there will be dilatation of the proximal bowel. There is dilation of the proximal bowel, the resident bacteria will proliferate, like Klebsiella and E. coli will proliferate. This will elicit inflammatory response from neutrophils and macrophages, and this causes the proteolytic enzymes released by inflammatory cells will damage the secretory and motor processes of the intestine, and also it causes increase in nitric oxide, local production of nitric oxide, which causes further dilatation of the proximal bowel. So we saw initially there is vigorous peristalsis followed by absence of peristalsis, and then later paralyzed and dilated duct, bacterial proliferation, which in turn causes dilatation to worsen. Due to impaired permeability of the membrane mucosa, which is secondary to damage by bacteria and as well as the damage by inflammatory cells, due to the mucosal damage, there will be fluid sequestration inside the bowel. Fluid sequestration inside the bowel, the dilated, paralyzed bowel. This causes dehydration and electrolyte abnormality. This is seen till in first 12 hours. After first 12 hours, as the bowel goes on dilating, the intraluminal pressure, the pressure inside the lumen of the bowel, reaches such a point wherein it crosses the bowel wall venous pressure. Once the intraluminal pressure becomes more than bowel wall venous pressure, it occludes the lumen of the venous flow. It obstructs the venous flow, which causes ischemia. Again, due to ischemia, there will be bowel edema. And again, as the time goes on, the intraluminal pressure will goes on increasing. It may be due to the inflammatory process and impaired permeability of the mucosa, or due to the pooling of secretions from the stomach, from the saliva, from the pancreatic fluid. All these get pulled up proximal to obstruction. This will cause dilatation, which reaches to such a point that it compromises arterial supply to the bowel, causing gangrene of the bowel. This is the last stage, that is gangrene. The gangrenous bowel can rupture and may lead on to peritonitis, perforation and peritonitis. So along with this, the accumulated secretions along with impaired mucosal defense will cause increased bacterial proliferation. As I already told, this will secrete the toxins inside the lumen of the gut. Since the mucosa has already been damaged, the bacteria get easy access to systemic circulation. There will be septicemia followed by severe inflammatory response syndrome and multi-organ dysfunction syndrome. This is about the pathophysiological changes occurring proximal to the level of obstruction. At the site of obstruction, when there is obstruction, immediately there will be compromised venous drainage. Due to compromised venous drainage at the level of obstruction, when the venous drainage is compromised, it leads to congestion, the accumulation of blood and edema at the site of obstruction. Gradually, it leads to arterial supply jeopardized. When arterial supply is jeopardized, it leads to gangrene of the bowel wall. So this gangrenous tissue may perforate and cause peritonitis. We saw the peritonitis and the gangrenous bowel can be proximal to obstruction or at the site of obstruction. Distal to the obstruction, since there is no gastrointestinal contents going into the distal part of the bowel, distal to obstruction, it will be inactive and completely collapsed. Then we have other concept, that is closed loop obstruction. Closed loop, the name suggests, there is obstruction at the level of opening and ending, that is obstruction at the level of two sides. Here you can see it can be, the closed loop obstruction can be in the small bowel, where in the volvulus there will be constriction ring formation at the proximal bowel loop and distal bowel loop, causing dilatation of closed loop, dilatation of bowel in between these proximal and distal obstruction. And also there can be closed loop obstruction in the colon, where there may be malignancy in the right transverse colon. This growth will cause obstruction. Then the competent ileocecal valve here at the ileocecal junction will cause another site of obstruction. The ileocecal valve will not allow the retrograde movement of the contents after obstruction. So there is obstruction at the two sites, causing the dilatation of this part of the colon, and this may eventually form stercoral ulcer, which is an ulcer formed due to the hardened pressure necrosis due to the hardened feces, causing pressure necrosis of the mucosa. Following this, there may be fecal peritonitis following the formation of stercoral ulcer. This about closed loop obstruction. Then we'll see the clinical manifestation seen in intestinal obstruction. The clinical manifestation seen in intestinal obstruction are: the first and most important symptom, we have abdominal pain. The abdominal pain is sudden and severe. Initially, the patient will experience intermittent colicky pain due to obstruction. And later, we know that there will be strangulation and there will be gangrenous changes. This will cause diffuse persistent pain. The pain in small bowel obstruction is crampy, and the recurrent paroxysm of pain is seen every 30 seconds. At interval of every 30 seconds, we see recurrent paroxysm of pain in small bowel obstruction. The pain has crescendo decrescendo pattern, that it will increase and then decrease, crescendo decrescendo pattern. In case of large bowel obstruction, the pain goes on for minutes and then it recurs. In case of small bowel, we saw it recurs every 30 seconds. In large bowel, it takes more time to recur. In adynamic obstruction, the pain will be mild and it will be diffuse in case of paralytic ileus, adynamic obstruction. Next, we saw abdominal pain. The another symptom with which the patient can present with is vomiting. In case of jejunal obstruction, there will be early and persistent vomiting. In case of ileal obstruction, there will be recurrent vomiting for leaving behind the interval, meaning that the vomiting occurs at an interval. The vomiting initially is bilious, followed by feculent vomiting. In large bowel obstruction, vomiting is a late feature, so we usually don't see vomiting in case of large bowel obstruction. Next, we have abdominal distension. It will be minimal in case of jejunal obstruction. In case of ileal obstruction, there will be abdominal distension, along with which we hear bourboigne sound. Sound is normally heard when we are hungry. You can notice that migratory motility complex will produce this sound normally, but in these patients with intestinal obstruction, they'll have persistent and increased pitch of bourboigne sound. Then the patient can have visible intestinal peristalsis proximal to the level of obstruction. We saw the initial vigorous peristaltic movements is seen in intestinal obstruction. This visible intestinal peristalsis is also be described as step ladder peristalsis. In case of large bowel obstruction, the abdominal distension will be enormous compared to that of ileal and jejunal obstruction. The patient, along with these features, will have absolute constipation, that is, inability to pass feces and also inability to pass flatus. Then, on examination, we'll see abdominal tenderness. Initially, it will be localized. Then the patient will develop a diffuse abdominal tenderness. If the patient has rebound tenderness and galding, it suggests peritonitis in the patient. Then the bowel sounds. The bowel sounds that we hear in case of intestinal obstruction is high-pitched metallic sounds. We hear it due to the increased peristaltic movements, the rigorous peristalsis that I explained initially. There will be increased high-pitched metallic sounds, followed by metallic tinkling sound, which is due to the passage of the intestinal contents to the partial intestinal obstruction. Then it is followed by fatigue of the muscles and absence of bowel sounds. On digital rectal examination, the rectum can be empty and dilated. If the rectum is not involved, if the obstruction at the level of ileum, jejunum, or colon, the rectum will be empty and it will be dilated. If the obstruction is due to the carcinoma in the rectum, we can feel the growth on colorectal examination. This is about the examination findings seen in intestinal obstruction. In advanced cases, the patient can have oliguria. We saw the patient can have dehydration in case of intestinal obstruction secondary to impaired mucosal permeability and the bacterial infection. So due to dehydration, the patient can have acute renal failure and he will have oliguria. Due to sepsis, the patient can have tachypnea, tachycardia, and altered sensorium in advanced cases. This about the clinical manifestation seen in intestinal obstruction. Then we have investigation findings. First, we have blood investigation. On doing blood investigation, the hemoglobin levels can be low in case of if the patient has malignancy as the cause for intestinal obstruction. The WBC count may be increased if the patient has developed sepsis. The renal function test can be impaired if the patient has acute renal failure secondary to intestinal obstruction. On plain X-ray, we'll take erect plain X-ray and as well as supine plain X-ray. On erect plain X-ray, the patient will have multiple air fluid levels. The reason for which I mentioned, due to rigorous peristalsis, there will be churning of air through the obstruction and it leads to multiple air fluid levels. So usually there is more than or equal to 3 air fluid levels in case of intestinal obstruction. Here you can see the air fluid levels where it's marked by the horizontal line and a gas which is seen as this shadow, the gas shadow. So below this line there will be fluid and above it there is gas. This is called as air fluid level. It will be more than or equal to 3 in case of intestinal obstruction. This is about the plain X-ray where we see multiple air fluid levels, that is more than or equal to 3 air fluid levels in case of intestinal obstruction. The small intestine more than or equal to 3 centimeters suggests intestinal obstruction, and we can do supine X-ray in order to find out the site of obstruction, where the proximal to the site of obstruction, the bowel will be dilated, and distal to the site of obstruction, the bowel will be collapsed. By this, we can point out the site of obstruction by X-ray. The CT scan is more reliable compared to the X-ray, where small bowel, if intestinal obstruction is there, it will be more than 2.5 centimeter. The USG abdomen will show dilated bowel with fluid in peritoneal cavity. This is about the investigation findings seen in intestinal obstruction. Then coming to treatment, we have initial conservative management followed by definitive management. In initial conservative management, we'll keep the patient nil per oral, and then we should do nasogastric aspiration. The reason for doing nasogastric aspiration is in order to reduce the bowel distension so that there is improved pulmonary ventilation. And also the nasogastric aspiration will reduce the risk of aspiration pneumonia. So we should do nasogastric aspiration followed by IV fluid administration to the patient, usually ringer lactate, because they can have dehydration and electrolyte imbalance. And then we can give IV fluids covering both anaerobic and aerobic organisms, that is ampicillin, gentamicin, and metronidazole. We can give IV analgesics, NSAIDs, and opioids to relieve the pain. Definitive management, we have emergency exploratory laparotomy, where we give midline incision. First, we will inspect the cecum, whether it is collapsed or distended. If the cecum is collapsed, it suggests small bowel obstruction. If the cecum is distended, it suggests large bowel obstruction. Then after seeing whether it is small bowel or large bowel obstruction, we'll identify the obstruction site and we'll relieve the obstruction. Following that, we'll look out for the viability of the bowel. We look out for a viability of the bowel by seeing the peristaltic movement. If the bowel is viable, peristaltic movements will be present. The non-viable bowel will be flabby due to muscle ischemia, and the appearance will be shiny if the bowel is viable. It will be dull and lusterless if the bowel is not viable. If the bowel is viable, you retain the bowel. If the bowel is not viable, we perform resection and anastomosis. Resection of the gangrenous tissue and then followed by bowel anastomosis. And following this resection of anastomosis, we'll give a peritoneal wash and then we'll drain the fluid. Following that, we'll close the abdomen layer by layer. This the definitive management, that is emergency exploratory laparotomy. Coming to some resection and anastomosis that we do in case of intestinal obstruction. In right-sided colonic obstruction, we do right hemicolectomy with ileocolic anastomosis. Right hemicolectomy will perform, and then we can do ileocolic anastomosis. In case of left-sided colonic obstruction, we do left hemicolectomy, followed by colonic anastomosis. Colonic anastomosis will perform, and then we'll perform right-sided defunctioning colostomy. What is this defunctioning colostomy? Proximal to anastomosis, we'll take the colon and anastomose with skin to perform end colostomy here. So this defunctioning colostomy is performed in order to, so that the anastomosed part heals adequately, we'll perform this defunctioning colostomy. So after healing of this anastomotic site, after 6 to 12 weeks, we'll close the defunctioning anastomosis. This is left side is colonic obstruction. Then in case of left side colonic obstruction, if the obstruction is at rectosigmoidal, due to rectosigmoidal growth, we'll remove the rectosigmoid part, the involved rectosigmoid part, and then we'll perform the closure of distal stump and end colostomy of the proximal stump. This is called Hartmann's operation. After 6 weeks of performing this end colostomy, we'll do colorectal anastomosis. This about the treatment of intestinal obstruction, characterized by inability of intestinal contents to move distally. The 80% of intestinal obstruction that we see is small bowel obstruction, 20% of it is large bowel obstruction. In 80% of the times, the small bowel obstruction is due to benign conditions like adhesions, hernia, whereas in case of large bowel obstruction, 70 to 80% of time, it's due to malignancies. We have dynamic and adynamic obstruction. In dynamic obstruction, there will be mechanical obstruction. In adynamic obstruction, the obstruction is due to loss of peristalsis. The dynamic obstruction causes are adhesions, hernia, malignancy, tuberculosis, Crohn's disease, gallstones, roundworm, and specificated feces. The causes are classified as outside the wall, in the wall, and in the lumen. Then we have adynamic obstruction. The paralytic ileus can be due to post-surgery, spinal injuries, or due to uremia. Coming to pathophysiology of this condition, proximal to the obstruction, initially there will be increased peristalsis, that is vigorous peristalsis, so that the obstruction is relieved, followed by the peristalsis will cease due to fatigue of the muscles. The bowel proximal to the level of obstruction will be paralyzed and dilated. And then we have proliferation of bacteria, which also damages the secretory and motor processes of the bowel and also causes increased nitric oxide production, which further dilates the bowel, proximal bowel. Due to mucosal injury and impaired permeability, there will be sequestration of fluid inside the intestine, leading to dehydration and electrolyte imbalance. This is seen in first 12 hours. After 12 hours, there will be increase in intraluminal pressure more than bowel wall venous pressure, leading on to ischemia. And then there can be compromise of arterial supply. There can be secondary gangrene and leading on to peritonitis. At the site of obstruction, and also before moving to site of obstruction, the accumulated secretion and impaired mucosal defense will cause the increased proliferation of bacteria, which causes the septicemia, SIRS, and multi-organ dysfunction syndrome. At the site of obstruction, there will be compromised venous drainage, so there will be congestion and edema, followed by arterial supply geoparditis, which causes gangrene of the bowel. Then there can be, following gangrene, there can be perforation and peritonitis. The bowel distal to the site of obstruction is inactive and collapsed. Clinical manifestations are abdominal pain with sudden, severe, and initially colicky, and followed by diffuse persistent pain. Then the patient have vomiting. In jejunal, they have early and persistent vomiting. In ileal, they have recurrent vomiting, which is initially bilious, followed by feculent vomiting. And then in large bowel obstruction, we don't usually see vomiting. It's a less feature in large bowel obstruction. Abdominal distension is minimal in jejunal obstruction. In ileal obstruction, abdominal distension is present with stepladder peristaltis and Borgogni sound. And also there will be enormous abdominal distension in case of large bowel obstruction. We see absolute constipation in intestinal obstruction. Then in advanced cases, we see oliguria due to acute renal failure, and sepsis. We can have tachycardia, tachypnea, and arterial insomnia. Examination findings are abdominal tenderness. Initially, it will be localized. Later, it will be diffuse. If the patient has rebound tenderness and guarding, it suggests peritonitis. The bowel sounds, initially it will be high-pitched metallic sounds due to the vigorous peristalsis seen initially, followed by metallic tinkling sound, and later followed by absence of sound. Here it's the high-pitched metallic sound heard. Then we have the digital rectal examination. If the obstruction is proximal to the rectum will be empty and dilated. If the obstruction is due to CA rectum, the growth can be felt on digital rectal examination. Investigation findings on blood examination, it can be the hemoglobin level can be reduced in sepsis, WBC count increased, RFT can be impaired in acute renal failure. There will be multiple air fluid levels more than or equal to 3 air fluid levels. On supine X-ray, we can see the site of obstruction. The proximal bowel will be dilated, and distal to the obstruction, the bowel will be collapsed. On CT scan, if the small intestine is more than 2.5 centimeters, it suggests obstruction. On USG, we can see dilated bowel and fluid in peritoneal cavity. Initial conservative management, we have nasogastric aspiration, IV fluids, IV antibiotics, and IV analgesis. IV antibiotics should cover both aerobes and anaerobes, so we give ampicillin, gentamicin, and metronidazole. The definitive management is emergency exploratory laparotomy. First, we'll visualize the cecum. We'll see whether it's collapsed or distended, so that we can see whether it is small bowel obstruction or large bowel obstruction. Followed by that, we identify the cause of obstruction and relieve the obstruction. And then we check for viability of the bowel. If the bowel is viable, we retain it, or if it's not viable, we perform dissection and anastomosis. Following that, we perform peritoneal wash, and then we'll aspirate the fluid inside the peritoneal cavity, and then we'll close the bowel, close the abdomen layer by layer. Then few resection and anastomosis procedures are: in right-sided colonic obstruction, we perform right hemicolectomy with ileocolic anastomosis. In left-sided colonic obstruction, we perform left hemicolectomy with colocolic anastomosis, and right-sided defunctioning colostomy, which is closed after 1 to 12 weeks. In rectosigmoidal growth, we perform Hartmann's operation, where the end colostomy is performed, and after 6 weeks, this end colostomy is taken in, and we perform colorectal anastomosis.